I would now like to move to an area that is important to our patients. It's a target organ that is often involved in both hormonal therapy and chemotherapy, and that's the bone. We talk about bone health both in the early stage setting and certainly in patients that develop bone metastases. They experience significant morbidity from this. Joyce, starting with metastatic bone disease, can you tell us what your general management approach is? Fortunately, we have some new players in the field, and it's given us certainly a new handle on treating this, but certainly also confuses the choices we have.
Yeah, we do have some. It's been revolutionary, obviously. It's been terrific for our patients to have way fewer skeletal-related events and improve their quality of life tremendously. There were 3 large randomized trials looking at denosumab, the monoclonal antibody against the rank ligand, subcutaneous injection monthly versus IV zoledronic acid monthly, one in metastatic breast cancer, one in metastatic prostate cancer, and the third was non-small cell variety of solid tumors and myeloma. And basically, the only place where it didn't look superior to zoledronic acid was in the myeloma. So it's not approved for myeloma, but it's approved for all solid tumors. And in metastatic breast cancer, it had a 18% relative reduction in the risk of a skeletal-related event, both the first skeletal-related event as well as cumulative, because it was first and subsequent was also a secondary endpoint of the trial. So it had superiority in terms of reducing the risk of skeletal-related events with less in the way of renal toxicity. It did have about the same in terms of the risk of ONJ, 1 to 2%, both arms of the study quite low, but no need to check the creatinine. Now, it does cause hypocalcemia, and so patients do have to take calcium and vitamin D. You know, my own personal experience, that's really, I've only seen that in the setting of some reduced renal function to start off with. So it certainly is convenient for the patient as well. So I actually think both of those options are quite reasonable. I think that the magnitude of the benefit, wasn't so large that one is obliged, to utilize the denosumab. I actually think both are, equally, good choices, and I think they're both, supported by the NCCN guidelines quite robustly. But it's a very interesting novel mechanism because the rank ligand may also be involved in stem cell biology. And so, of course, the DCARE trial, which is the adjuvant denosumab trial, has now been completed in enrollment. So we look for that, to see whether or not it will decrease breast cancer recurrence in bone and outside bone. So I personally favor the denosumab as my choice, for patients with newly diagnosed bone metastasis or those progressing on IV bisphosphonates. I'll tend to use the denosumab for patients.
One of the things we're challenged with these clinical trials is the efficacy of the drugs was actually usually 1 year. They have a couple of years of safety data on these drugs, but we don't really understand, for the most part, the continued benefit of any of these classes of drugs 2, 3, 4 years out. And as you know, our patients, especially with bone-predominant disease, are on these drugs for a long period of time. So long-term toxicity, I think, is still an open question for these drugs. And really whether the schedule of monthly forever is the right one. I know that's being addressed in part of clinical trials as well, of once they get to 9 months of monthly, they're being randomized to every 3 months versus continuing monthly. But for zoledronic acid to be on the market for as long as it has, there's so much we don't know about that product at this point.
And seeing all the gains we've made in metastatic disease, where I think we'd all admit, even though the numbers speak for themselves from the clinical trials, those of us that have been in practice for a long time know that we certainly see many fewer admissions for hypercalcemia, for significant bone pain, for bone complications. That's really a thing of the past. Our fellows in training have no idea that back 20 years ago, half the patients on the ward were being admitted for complications of bone disease. So translating that in the early stage setting now is a big issue. Obviously, the complication rate is lower, certainly in the short term, but we don't know what it is in the long term. Our patients that are getting adjuvant therapy for early stage breast cancer are at risk for complications from bone disease and will be at risk really for the rest of their lives.